There are a couple of questions I think that are very general and I should probably address. I do Sudoku crosswords often, but my daughter says I need to do memory games because I'm forgetful. If you can do memory games and it's within your capacity to do so and it doesn't frustrate you, continue to participate. But engaging with people on a regular basis, conversation, reading, doing the things that you know to do and can do well, keep doing those things. That's the best exercise. Is concentration better than Sudoku? If it's frustrating you and it's hard for you, it's probably not a game that you should participate in. Okay. There are a couple of questions we have here about autopsy and can I donate my brain and my body to research? In our Alzheimer's Disease Research Center, we do accept brains and spinal cords, but we want them, they have to come fresh, but we want them before you don't need them anymore. So we need to know more about you before you give those very important gifts. So if we start out like today, for example, and we're functional or not functional, and maybe we have mild cognitive impairment, maybe we have Alzheimer's, maybe we have Parkinson's or Lewy body, but we don't really know what's in that brain until it's been analyzed through autopsy. So we have something called the memory program, and I think it's in your program. If not, our research coordinator, Latasha Chapman, does that. But if you're interested in donating your brain and your spinal cord to Alzheimer's research at our Goizueta Alzheimer's Disease Research Center, please see Ms. Chapman out there. There is research that's associated with it. We want to get to know you again before you don't need your brain anymore, so that we know more about you and can kind of like apply what you told us in life to what we find upon your demise. So yes, we do accept brains and we do accept spinal cords, excuse me, for autopsy. I'm going to address a question about nutrition and aging. You've probably read a lot of things about the Mediterranean diet and this diet and that diet, the mindful diet, mind diet. The most important thing that I can say that's most instructive about nutrition is if you're not sure about what you need to eat and you need better guidance, confer with a dietitian. The hospitals, just about every hospital has a dietitian who can kind of create a tailor-made diet for you in terms of what's necessary for you. But in terms of overall health, we always say what's good for your heart is good for your brain. So things that are low fat, not fried, more fruits and vegetables. How many of you have seen the My Plate cartoon? I call it a cartoon, but it's sort of like guidance on what people should eat. A colorful plate, more fruits and vegetables, lean meats and proteins. Okay, what are you holding up there? Very good. He says he's holding up oranges. So more fresh fruits, more unprocessed meat, things. I think I'm still waiting for my timekeeper. You'll get started? Okay, Cornelia is going to start us off. Our next presenter comes from the Mayo Clinic, and he does an extensive amount of brain research and Alzheimer's research at the Mayo Clinic, and one of his areas of research is blood biomarkers that we referenced and talked about a little bit earlier. So at this time, I'd like to introduce you to Dr. Neill Graff-Radford. I always stumble on his name because I had a colleague who had a similar name, but it was a little different. But I keep calling him the other Neil. Thank you, Dr. Neill Graff.
Thank you so much for inviting me to participate in this really outstanding program. I'm really enjoying all the lectures and myself. So my dad lived to 102, and he loved to tell jokes. So here's one of his jokes. There were these three men playing cards, and the one said to the other, "You know, I went to my doctor and he's helping me with my memory." "Oh, what's he doing?" He says, "Well, number one, I must make associations." And number 2, I must take the new medicine. He said, well, what's the name of the new medicine? He said, well, let me see. I see a flower. It's got thorns. It could be yellow, could be red. And the other men said, rose. He said, yes, that's right. Rose, what's the name of my new medicine? All right, so I'm going to go through what I tell my patients to prevent for brain health, what I tell them for brain health. And then I'm going to talk a little bit about biomarkers and also expand a little bit on what Jim talked about on treatment. And I'm also going to add a little bit on prevention. We're going to try and do that in 20 minutes. Here we go. I don't have any disclosures. So you've seen August Dieter, but I'm not sure you saw Dr. Alzheimer's history. This is what the history was. He said to her, what is your name? And she said, August. What is your last name? And she said, August. And what is your husband's name? And she said, August, I think. And how long have you been here? She seemed to be trying to remember, and he wrote in his notes, 3 weeks. It was only 2 days. And then she said, I lost myself. So poignant, wasn't it? Isn't that over 100 years ago that you'd lost your mind? It's one of the saddest diseases out there, isn't it? All right, and the epi is interesting because it's changing. You know, it is going up. You see these are different studies looking at greater or higher or lower or medium, how many million people are going to have in Alzheimer's in America, maybe 13 million by 2050. But what's interesting is actually that dementia is going down. You heard the umbrella, dementia, not Alzheimer's disease. Dementia is actually going down. And this is from the UK, and actually this is confirmation from the United States. So maybe it's those primary care doctors that are doing a great job treating your blood pressure and cholesterol and other good things, good information. So pay good attention to your annual visit. Alzheimer's is not going down, it turns out. All right, so what are the risk factors then? And getting older is the most important risk factor. We don't want to prevent that, right? Family history, and then really a lot of it is genetics. And it turns out that in the twin studies, 60 to 80% of risk of Alzheimer's is genetic. So, but remember, don't get panicky about that. You know that hypertension has genetic factors, but we can treat it, or high cholesterol has genetic factors, but we can treat it. So, but that is likely the most important risk. Well, let's look about putative protective factors. A lot of this comes from epidemiology, so putative means it's not proved, it's an association often. So the first study was in education. This is the study from Shanghai by Dr. Katzman, where he showed that women, it turned out, who were illiterate had a greater chance of developing dementia. I remember him presenting this study, and everybody said, Dr. Katzman, how did you test illiterate people for dementia? Was it a pencil and paper test? And, you know, so we were teasing him. But he turned out to be right, that it is actually true that the better the education, the less chance. The nun study was very interesting, which happened a few years later. And nuns donated their brains to research, like many of you have done, will do maybe one day, signed up for it. So this very, very clever linguist looked at the essays the nuns wrote at age 23 in their own hand and analyzed it for density of ideas and grammatical complexity as surrogate markers of linguistic talent, and divided it into the lower half and the upper half. And the idea is that if you're a smart nun, linguistically, you'd still get dementia, right? But it wouldn't show. You'd have, quote, reserve. Well, the exact opposite happened, actually. The ones with high density of ideas had less tangles in their brain. At age 23, they had high density of ideas in what they wrote. When they died at 80, they had less tangles in their brain. Isn't that amazing? So what does that mean? Does it mean that the genes that cause you to be a smart nun also prevent you from getting tangles? Or does it mean if you're a smart nun, you're going to be a teacher, you're not going to do just cooking and keep your mind busy? There are a lot of hypotheses. We don't really know this, but it is very strong evidence. And this is a similar study from Aberdeen where they tested all 11-year-olds in 1932 for IQ. And you can see in the one column where you see dementia, and the percentage of the score that they had in those that at age 65 and older got dementia was much lower if they, at age 11, their score at age 11 was much lower if they lived to 65 in Aberdeen. So being a smart 11-year-old actually is protective of getting dementia, interestingly. So they said, well, we've got mice. We'll put the gene in the mice. They make amyloid. And let's see if we can look at the environment of the mouse and see if we can do it. Well, they enriched the environment of the mouse. They gave them an exercise treadmill for them. They gave them a bigger cage. They gave them toys to play with. And lo and behold, you can see enriched environment and regular environment, standard environment, and the enriched environment prevented amyloid being deposited in the brain. So you should enrich your children's lives. All those soccer moms are doing great jobs, aren't they? All right, so that's a good thing to know. And blood pressure is really, really important. This is the famous SPRINT study where they treated people for a systolic blood pressure of 140 versus 120. And those who they treated to 120 versus the 140, the ones at 120 got less cognitive impairment in 3 years. So treating your blood pressure is really crucial in your brain health. This is an interesting study from the 3C study from France, where they had people who had dementia. And some of them, they had their vascular risk factors treated, and some of them had some vascular risk factors treated, and some had no vascular risk factors treated. The ones where their vascular risk factors were not treated, these were people with dementia, is the lowest blue. And their mini-mental scores, they started with dementia at 20-something, and their mini-mental scores went down. So treating vascular risk factors slows down the progression of cognitive decline in demented individuals. Isn't that interesting? Here's a fascinating study from Medicare. So people are prescribed statins, and some take them and some don't. So this is looking at the thousands of people who were prescribed statins and who got dementia, and they looked at those who took their statins because they refilled their prescriptions, and those who didn't take their statins. And those who took their statins had less chance of getting dementia. It's pretty powerful evidence that treating the cholesterol actually is good for your brain health. And exercise, you've heard that exercise, we've just done some exercise. I thought that was super program. He's unbelievable. Anyhow, this is a randomized prospective study. It's level 1 evidence for people who had exercise. And this is from Champaign, Illinois. And what happened in those who did aerobic exercise, you heard 30 minutes a day, 150 minutes a week, that's what was done, versus toning, stretching, and balancing. And their hippocampal volume, which is the memory part of the brain, increased in size. Look at that top line. It wasn't anywhere else in the brain. It wasn't the thalamus or the caudate nucleus. It was the hippocampus increased in size. And not only that, those who were fitter, their peak oxygen consumption, which is a measure of fitness, was associated with a bigger hippocampus. And the brain-derived neurotrophic factor, which is one of the factors that nourishes the brain, increased with exercise as well. You can measure that in the blood. And memory improved with this as well. So a randomized prospective study in cognitively healthy people age 68, exercise showed it was helpful. Randomized prospective study. And it turns out that there's dominantly inherited Alzheimer's. 1% of people who have Alzheimer's have that. If you have that gene, you will get the disease at age 40 or 50, highly penetrant. So they took the people who had the gene, and they looked at those who exercised, did 150 minutes or more, and those who did 150 minutes or less. And they looked at the age of onset of those. They all had the gene, and the age of onset was 14 years later. So exercise again. I hope you guys all believe in exercise now. And so this is the Harvard study showing that those who have amyloid in their brain, that biomarker, if they exercise, their cognition is slowed down. So this is the Harvard study of aging, showing that even if you have amyloid in the brain, exercise is good for your brain. And then there's the women's health study, the Harvard study on nurses aging, and alcohol in their study showed that one drink was safe and actually was healthy. But this is controversial, so newer data shows that alcohol actually is not too healthy. So I think if you're going to drink moderately at least. Don't drink too much. All right, and how about those antioxidants? You know about those colored fruits and veggies on your plate. Those are your antioxidants. And they did a study with elderly beagles, and they gave them antioxidants. This is the food. And amazingly, the elderly beagles started learning new tricks. So maybe you could be elderly beagles. Here's the Mediterranean diet. There's a randomized prospective study showing that the Mediterranean diet is protective of the brain. So there is was some controversy with the study, but there have been other studies like the MIND diet, epidemiologically, which is very similar to the Mediterranean diet, plus the DASH diet, which is the blood pressure diet. So lots of fruits and vegetables, whole fruits and vegetables, and less meat, more fish, lots of olive oil, no butter, less cheese. That's basically the MIND diet, which is helpful. There's been a randomized prospective study doing the MIND diet, but only for a short time. I think these kind of effects are relatively small and take many decades for them to be really effective. and it's very hard to do such a study. So this is the data from the MIND and the DASH diet. This is the new Framingham study, again, showing that actually diet is really very helpful to the brain. So here's my recommendations. First, this paper showing that if you take those diphenhydramine or Tylenol PM or NyQuil PM or Ditropan, any anticholinergic, trazodone, amitriptyline, all of those medicines have long-term effects, not just short-term effects on your cognition. So try not take those sleeping tablets. Maybe melatonin would be okay. And sleep apnea, there's studies showing that the hippocampus shrinks if you have sleep apnea, but interestingly in one study, increases in size if you treat the sleep apnea. So now you know that exercise increases your hippocampus and treating sleep apnea maybe. And then this is the dental evidence. You heard that earlier, that so keep your teeth in good condition. And sorry, I can't see very well from here. Let me go close up. This is the 2-year, this is really important. This is the randomized prospective study called the finger study. So this is actually putting into practice what I said, and that is people who have vascular risk factors, have their diet treated, and do the exercise as well, their cognition increases in 2 years. That's the finger study. So this is the recommendation on prevention. There are diagnostic criteria now for dementia, and and so there's a sequence of events that happen. What is that happening? Back up the slide. One more. All right. You got a picture? Sorry about that. Do I have a few more minutes? All right. I just want to talk to you about the sequence of events in the brain. First, amyloid is deposited 20 years before. Then the brain stops functioning well. The deoxyglucose shows the synapses don't work. Then you get the tau deposited. Only then does the brain start shrinking, and only after that do you get mild cognitive impairment. And then eventually you get dementia. So there's a lot of opportunity before you get dementia. The dementia is the tip of the iceberg. We've got to treat the bottom of the iceberg, the prevention. And so there's different classifications. I'm running over time, so I'm going to stick to some of the crucial parts of biomarkers. The blood test for the phospho-217 is now at least 85% accurate in detecting whether people have amyloid in their brain on a PET scan. And we think it's going to be even closer to 90, the phospho-217. So we are already using it in our clinical trials. Before we do a PET scan, we do a blood test. If their blood test is positive, then they go on to a PET scan. So it really saves a lot of money in our prevention studies. So this is the Clarity study, which is the study that showed in a randomized prospective study that lecanemab or Leqembi slows down the progression of Alzheimer's disease at the mild cognitive impairment study, and on average, 27%. But I want you to understand that 50% of the people didn't get worse on this drug. 50% of the people, 27% is the average. So some got worse, some didn't. So there is a group of people out there who have very mild, and we think less tau, who this Leqembi is really going to work much better than others. We need to find that subgroup. And the last point I want to talk to you about is you've heard the side effects. I'm not going to go over those for you, but I want you to understand what we're doing now. And that is, these are the two studies, the Trailblazer and the Trailblazer and here, one back. The prevention studies are the most important studies. We are recruiting cognitively normal people. Many of you in this audience may be candidates. Screening them with a blood test. If their blood test is positive, doing a PET scan. If their PET scan's positive, randomizing them to receive Leqembi or donanemab, and then removing the amyloid and seeing if we can prevent you getting the Alzheimer's symptoms. That is a tremendous hope. We really, really think that's got got good support because we know that the mildest patients that we treat seem to do the best in these studies. I'm going to stop there, and I'm sorry for going over, but I appreciate the time. Thank you.
In the interest of time, we're going to have Dr. Wang and Dr. Hendler make their presentations, and if you continue to write your questions down, we'll ask them in a little conjoined session. Dr. Wang.
All right, well, first of all, I want to thank Monica and her team for doing such an amazing job with these outreach events. I'm sort of the parallel. Monica talked about a network, and I'm part of that network of Alzheimer's disease research centers. I'm based at Indiana, so I share that hat, and I know a tremendous amount of work has gone into this event. So I really want to, first of all, just give them a round of applause for doing such an amazing job. Thank you so much. Okay. So I know the title of my talk is a little bit different than what's in the agenda, but it really hits to the heart of what we need to really cover, honestly, in about the next 15 minutes or so. And that is, how can you begin to have a conversation with a healthcare professional on behalf of yourself or someone that you love about psychotropic use? My role as a geriatric psychiatrist is to really take care of that everything else that Monica talked about. When we look at the brain, we begin to realize there's a lot of complex pathologies. And I think our previous speakers have really kind of drilled it down, with Alzheimer's disease, we should start to think about beta amyloid, we should start to think about, phospho-tau, the different isoforms. But if I were to say, name one protein, right, that is associated with the pathology of behavior, there wouldn't be one to describe it. And that's how complicated that mind is. So I don't have any relevant disclosures. We may be discussing some off-label use, but if you have questions about specific medications, I want you to encourage you to talk to your doctor. So what does a geriatric psychiatrist do, and why do we need to have this conversation? So first of all, I'm just going to be very honest. There will never be enough geriatric psychiatrists to provide the care that we need for our population as they get older. So part of my job as I go out and educate communities to teach you how to begin to have that conversation, whether it's with your primary care doctor, your neurologist, or geriatrician. And when should you gently cue them to get them to come see a specialist like myself? Because the access times can vary anywhere from 1 to 6 months, right? And you don't want to end up with your loved one in the emergency room. So when are some times that you should start thinking about a geriatric psychiatrist, and how should you begin to have that conversation? So as a practicing geriatric psychiatrist, people are like, well, what do you do? Well, actually, a third of my job is simply actually not doing anything. It's watching and waiting, but it's actually having a conversation with your other healthcare professionals about not prescribing psychotropic medication and what else needs to be done, whether it's in the outpatient setting, an assisted living facility, a memory care facility, a nursing home, or the emergency room. So for a moment, forget the names of the medications. Just think about what these drugs can do and can't do. So what do psychotropics not fix? It will not fix somebody who has an underlying medical condition for acute changes in behavior, okay? So if your loved one develops an infection in their lung or their urine and they become more confused and they become agitated, right? And they start to yell or threaten someone because of the level of confusion, and this is an acute change from who they are, giving them a psychotropic will not fix that problem. And I think it's probably one of the biggest mistakes that I see is that people do not often get the medical workup that they need for a potentially life-threatening infection. And it's really important that gets treated, because untreated delirium has very high mortality rates. In older adults, it can be as high as 30 to 50%. It's even higher in patients who are in nursing homes. Okay, so that's probably the biggest concern that I see. So what's the other second thing that you need to be probing your healthcare professionals for? So I think one of the most concerning things that I get referrals for is when healthcare professionals, settle for a single answer. I'm very glad that Monica felt comfortable sharing her story about the complexity in the brain. It is rare that someone has a single problem with their brain by the time they get to see a subspecialist. So for example, they'll see somebody with some depression and anxiety, they'll give, say, an antidepressant or an anxiety medication to treat that, and they're like, oh, it's all good. But we have to probe more deeply. We are beginning to think about brain health, not just cognition, but also behavior. Depression and anxiety are risk factors for cognitive decline. And so if somebody especially has new onset depression and anxiety, and they're even noticing mild memory concerns, it's time to get that workup. We've been talking about the importance of early detection, but the field, and maybe next time we can talk more about this, is beginning to recognize the importance of early detection of behavioral changes, known as mild behavioral impairment. And that's a new evolving idea that's going kind of hand in hand with mild cognitive impairment. All right, so what is the next biggest mistake I see? People often don't think about, and this is particularly in structured settings, they do not think about there's medical reasons for behavioral changes. So a common situation I see is physical aggression when someone is trying to provide direct hand-on care. So here's one thing that's always important to ask and probe as you talk to the nursing staff, as you talk to the healthcare professional. Why is my loved one doing that? Is there a reason? And what could be the reason? And in one case, it turned out it wasn't a psychiatric issue. They were actually in pain. They had severe arthritis. And when I spoke with the family, it turned out that the family member who knew them before their placement actually knew that, and they would give them Tylenol before they changed them. But when they moved to the facility, that key information, that personal information about their loved one was lost. And so part of the answer was actually just getting a really good story from somebody that knows that person well. Each of you are special individuals. You can have the same biomarkers and yet be completely different in terms of your behavior. To me, that's actually one of the most fascinating things as a psychiatrist, right? And so really having someone that can tell them your story and help understand the medical conditions and advocating for that is really important. And once that person was given their Tylenol that they always had, they actually stopped hitting because their pain had been treated. All right, now, I know we call it clinical judgment, but let's just call it, as Monica would say, common sense. Okay? And sometimes taking that huge step back, that 50,000 feet look, is really, really critical. So for example, sometimes, and this is where geriatricians are really important, is knowing when you should apply evidence-based guidelines versus, hey, let's take a breather here. Let's take a look at the person. So for example, there was someone who was like hitting the nurse whenever they tried to do the finger sticks. And of course they called me up and said, hey, this person's agitated early in the morning. I started looking at their chart. I'm like, why is this person getting finger sticks? They don't have a diabetes diagnosis. Why did they start doing that? Well, it turned out they had been discharged from a hospital. So you notice transition of cares are really important. We send huge stacks of paperwork. How many people really have time to read those 50 pages of medical records? This is something very important. You as a family member, taking care of your loved one, you need to know their story. Turned out that somebody had ordered it because they had a slightly elevated glucose and they were trying to monitor for diabetes. But they didn't really actually need to continue that. Even worse, it turned out that person was not a morning person, actually. So they were taking somebody who wasn't a morning person, who didn't need finger sticks, to get the finger stick. I was like, what happens if we stop the fingers? Oh, we can't do it to monitor for prediabetes. I was like, okay, let's kind of take a step back. This person has moderate to severe dementia. Are you really going to aggressively treat this? So guess what? They let go of it. The problem was fine. They did finger sticks at a slightly later hour, right, because it just needed to be fasting, and turned out the person didn't have prediabetes and didn't need psychotropic medication. All right, but 1/3 of my job is actually giving medications. So when does somebody like me need to give medications, and when should you start having that conversation about medications? So I sort of categorize it in 3 different sort of settings in my mind. The first one is acute inpatient and hospital, medical floor, surgery, ICUs, emergency rooms. Structured settings, we kind of talked about all the different, sort of structured settings, locked units, assisted livings, rehab is another one, skilled nursing facilities. And then outpatient, right? At home, somebody living in an independent facility, and community settings. All right, so when should I whip out my prescription pad and start writing a name of medication with a dose and a time? One of the times I'll do that is when they're eminently endangering themselves or others. So unfortunately, sometimes because of these types of dementias, people will, without any intention, impulsively take something and try to hurt themselves or their loved ones. That is one of the times they'll call me up and I'll be like, hey, we need to take care of this. We can't have, people being unsafe, either your loved one or you. Unable to accept urgently needed medical treatment. Okay, so we saw this, right? Somebody has a blood infection, somebody, needs those antibiotics. It will be life-saving. And the nurse has tried to put in the IV. The person has hit that nurse. They've tried a couple of times. They've tried to have their caregiver and their loved one calm them down. It has not worked. That is when I need to pull out my prescription pad, because I know if we don't treat that sepsis on time, they will die. Okay, that is when I step in. Okay, so that's the acute setting, and although we often think about rehab and still, memory care units as sort of outpatient, they can be sort of quasi-inpatient settings in which these acute, illnesses can occur. But most of the time, believe it or not, most of my job is to help people take a step back and say, do we really need medications, okay? And for a separate talk for another day, non-pharmacological management, behavioral management, such as DICE, ABC, which I'm sure, Monica and her team can share you more about, is often and should be the first line setting, and most importantly, should not be neglected even in the acute setting while we're giving psychotropics. All right, so I'm not going to go into any too many fancy drug names here, but I want to kind of list some broad categories. And one of the key things to keeping track of all these medications is to think about these as categories. So what are some categories in terms of how you want to think about medications when you're having a conversation with the doctor? So the first one is antidepressants. Although it says the word depression and anxiety are comorbid, it can often be used as that. It is actually also a first-line treatment for off-label use for mild agitation. Okay, so verbal aggression, where somebody might be, using strong language in a concerning way, could be that. Anti-anxiolytics. Rarely use them. There are a few exceptions. You know, we have, for example, REM sleep disorder and Lewy body dementia. But for most of the time, these are generally avoided. There's a few medical conditions in which I consider, but really should be avoided because of the increased risk of falls and at least, you know, evolving literature on, you know, cognitive impairment. It's different if someone's been on them for a while. That's a different conversation. But acute new onset use has to be thought through very carefully. Antipsychotics, so this may be a huge area for the Q&A, but delusions, hearing voices, agitation. Okay, there is no, there is actually, you know, it's all off-label use. And there's what we call a boxed warning for antipsychotics, and these should generally not be given as first line for off-label use except under emergent circumstances. And if there's ongoing prescription of that that's needed, which there are times that they are, it is time to get a specialist involved. All right, so when do I say, hey, medications are going to be important? Behavioral management has had no little effect. For example, hearing voices telling me to hurt other people, and they start becoming, and that's the key part, and they start becoming physically aggressive. Hearing voice itself may not necessarily be an indication, depends on what they're hearing. Endangerment to self and others. So verbal aggression alone is actually not endangerment. I mean, that's why I spend a fair amount of time telling people, like, before we put them on this medication, you know, let's really think about it. Are there ways that we can work around it? And then I think the other really important thing is quality of life, and this is where it gets subjective and where it helps to have that professional mental health evaluation is substantially impaired even after behavioral management. So somebody with severe anxiety who's pacing and pulling their hair despite staff attempts to distract them. They're not endangering themselves, they're not endangering anybody else, but it is disrupting their quality of life. So when should you start getting to a specialist like me? There are certain diagnoses that I tell people, I was like, please give me a call. I tell my fellow neurologists, if you start getting these, if you have a geriatric psychiatrist, we're here to help you. We're your friends. Frontotemporal dementia with behavioral issues, Lewy body dementia with psychosis. Often we love to work hand in hand with them. Endangerment to self or others, if you're visiting the emergency room or hospitalization, the biggest predictor of a psychiatric hospitalization is having been hospitalized on psychiatry. Those people need ongoing follow-up like that. So suicide attempts, physical aggression, especially involves police or emergency staff, it's time to give us a call. All right, failure, so again, this gets into the more subjective part, but failure to respond to initial treatment with antidepressants or anxiolytics. Now, fortunately, most of our cognitive behavioral neurologists and geriatricians are really wonderful for prescribing those first-line antidepressants. Some of them even feel comfortable providing a little bit of low-dose antipsychotics for, you know, aggression. But if the behavior, for example, the depression is not responding to antidepressant treatment, it may be a conversation actually for more, you know, I wouldn't say invasive, but actually more effective interventions such as ECT, actually, which has been shown to be very effective for geriatric depression. Bipolar disorder, again, very complicated disorder with manic symptoms needing mood stabilizers. Those require additional monitoring. Okay, so here are some frequently asked questions, and you can certainly take photos, by the way, but I'm going to give a slide to Monica. One of the great things about being an NIU fund is that we share our wealth with the public, so we will make sure it's available PDF for everybody who attends, and we can make that available also on our Facebook as well, just letting people know. So my loved one is starting a new medication. How fast should providers go? So the general geriatric rule, unless it's one of those emergent circumstances, it's best to start low and go slow. How long does it take an antidepressant to work? Yeah, it's anywhere from 2 to 8 weeks. And that's the thing. So there's a little bit of patience involved. And so one of the first things I do is I set realistic expectations on how long it takes. And but it's always better to start low and go slow. And you're like, well, why? I'm not seeing any effects. It's like, well, first of all, side effects are one of the most common reasons for discontinuation of medications. The other second thing is the more you go up, the higher the risk of drug-drug interaction. All right, so does my loved one need to understand what the medication is for? Well, it's a little bit complicated, but if your loved one doesn't have capacity to make medical decisions, I say keep it simple. This pill is going to help you feel more relaxed. You don't need to whip out the FDA insert and start reading it to them, okay? You know, that's TMI. But letting them know what's going on to a certain degree can be helpful. Now, if they really don't have capacity to make medical decisions, however, the healthcare power of attorney, the surrogate, the legal guardian needs to be able to consent to the medication administration. And whenever possible and reasonable, you should try to get their assent. You're like, well, what's assent? Assent is where someone may not fully understand every single detail in that FDA drug insert, but they need to be, on board, with the game plan, right? So if somebody, for example, has a loved one who's spitting medication back at them, they're really saying no to that. And we have to kind of begin to look at it and figure out how to more carefully, approach that question. But assent is when they say, I don't fully understand the details, but I'm on board. But somebody who fully understands every single detail needs to be consenting on their behalf in that case. All right, so boxed warnings. I think we saw one actually. I wrote this before lecanemab, but what is a box warning? So a box warning is actually the highest level of alert that the FDA can give. So whenever the next time anyone gets a prescription for themselves or a loved one, if there's a box warning, it'll be right at the top of that white piece of paper that everybody just throws in the recycling. Yeah, okay. But it'll be up there. And one of the most common questions is like, oh, antidepressants. There's a box warning. That actually applies to younger adults. Now, antipsychotics also carry a box warning of increased risk of death and other side effects for dementia with behavioral disturbances. And so that's where a really careful conversation of benefits and risks of taking the medication, should come into play. All right, so, okay, I think I've noticed my cue. Feel free to, if you want any more questions, feel free to email Monica, feel free to email us, and just tag me, and we'll make sure the slides are available. Thank you so much for having me.
So we are having questions. We're still collecting questions with our last presenters. Dr. Hendler, save the best to last. Come on, Dr. Hendler. Our geriatric dentist.
Okay, I always like to believe that they do save the best for last. So we've heard a lot of people mentioning oral hygiene and how important it is. We're going to delve into that more. So let's talk about oral health and brain health. Okay, we're going to cover what is oral health, why is it important, relationship between oral health and dementia. So first of all, what is oral health? And I want everybody to realize that it's not the fact that you have no cavities and that your gums are healthy. It's more encompassing. So this is from the International Dental Federation. Oral health is multifaceted, includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. Oral health is a human right, an integral part of general health and essential for overall well-being and quality of life. And from the World Health Organization, as we're talking about older adults too, one crucial and often neglected area of healthy aging is oral health. Poor oral health can have a profound bearing on general health and well-being, for example, through its influence on nutrition. Moreover, the experience of pain and problems with eating, chewing, smiling, and communicating due to missing, discolored, or damaged teeth have a major impact on functional ability and older people's daily lives. So that's oral health. What about oral disease? Well, you can have gum disease or periodontal disease, and that's an infection caused by bacteria where your gums get swollen, you start to lose the bone around your teeth, teeth get loose, teeth fall out. Another infection is cavities or dental caries, and there it's an infection, again, different bacteria that cause your teeth to decay and break down. Both of these infections can lead to abscess formation, and abscess formation, as we know, can lead to swelling, pain, and can often be life-threatening. The thing I like to point out is notice the one word infection is all of these definitions. Dental disease is an infection, and it should be treated as an infection, just as if we would treat an infection in other parts of the body. We wouldn't ignore it, we would treat it, and it's the same thing for the mouth. Why do we care? Well, in 2000, we had our first Surgeon General's report on oral health in America. And two key findings. One is that we need to improve oral health in America. But the other, I think more significant, was the fact that it was determined oral health is integral to general health. And 20 years later, well, it was a little over, it was supposed to be 20 years, but They issued a follow-up report, and this was from the National Institute of Health, Oral Health in America, Advances and Challenges. And what we found from this follow-up report is we still got a long way to go. So one of the findings was that 40% of people over 65 have a disability that affects their capacity to maintain good oral self-care and negatively impacts their accessibility and affordability of getting oral health care. People are keeping teeth longer. We know that statistics has bared that out, but we continue to have preventable dental disease as we're getting older. And one of the issues here is that Medicare does not cover routine dental care. And people rely on this as your health care, and it's not covering dental. Also, if you had dental insurance when you were working, okay, fine, but when you retire, that's it, you lose your dental insurance. So you're losing access to care, and private dental insurance is expensive and usually not worth the premium that you're paying for it. So we have discrepancies in medical care and dental coverage. Medicare is covering your health care, but it's not covering your dental. It gives the perception that, you know what, maybe dental is not really that important in older adults, because if it was, we would have insurance that would cover it, right? And this has made oral health care an elective part of our healthcare system. And I think, well, what they said was that it places the oral health and general well-being of every older American at risk. Now, I will tell you on a positive note, things are changing. Medicare is starting to cover dental procedures. Don't get too excited. They're very specific now, mostly medically necessary dental care, people that are going to have radiation for head and neck cancer, where we need to do things, diabetes. But I think it's a start, and there are a lot of organizations that is their focus, is to get dental care covered by Medicare. And all right, so have a little background on it. Oral health is important, and we know this because people are willing to spend a lot of money to have things done to their teeth to improve their smile. And why? Because they feel better about themselves. They're going to have more confidence in social interactions. Well, we also know that a healthy mouth is going to improve your general health. If your mouth's healthy, there's less infection in your body. And if there's less infection, there's less pain, you're going to feel better. Nutrition. Okay, this sort of makes sense, right? This is the gateway for food in our bodies. And we need, what you eat matters. And there have been a lot of studies that looked at dental status and food selection. And what we find is that people that have a poor dentition or an inadequate dentition tend to choose foods that are softer, which tend to be higher in carbohydrates and lower in protein. And that's definitely going to impact our overall health and well-being. Another thing is eating is a social activity. So people in assisted living, long-term care facilities, retirement communities, people come together to the dining room to eat. When we go on outings with friends, we go to a restaurant. It's a nice social interaction. Well, what if you're embarrassed by the way your teeth look? Or what if you're embarrassed because it takes you so long to eat a meal? Everybody's done and you're still working on the appetizer. Well, you may say, you know what? I'm not going to go to the dining room. I'm going to eat in my room. So you end up socially isolating yourself. And as the pandemic has shown us all too well, what social isolation does to cognitive ability. There have been a lot of studies that have found an association between oral health and systemic diseases. And these are out there, and it's not just in the medical literature. You see it in like the lay literature, like the Ladies' Home Journal. But there's relationships between cardiovascular disease, respiratory disease, diabetes, rheumatoid arthritis, frailty, depression. And there are studies now that are showing that periodontal disease and tooth numbers are related to all-cause mortality. So that's pretty, that's everything. Well, just to sort of summarize what we've said so far, oral health can impact general health. Okay, we mentioned that. Dental care can have a positive impact on quality of life. Infection in the mouth may be associated with disease in other parts of the body, including the brain, and we're going to get more into that because that's what we're here to talk about. But along the lines of infection, again, just because you're not seeing stuff out of sight, out of mind, oral health care needs to be done regularly. Most importantly is that dental disease can be prevented. And we'll talk about that too. So nothing magical here. And now we'll get a little more into it, but there have been a lot of studies, since we are talking about brain health here, there have been a lot of studies recently that have found a link between periodontal disease and dementia. So I just pulled out, just a couple that from recent years. I'm going to talk about this first one in more depth, but second one, tooth loss associated with increased risk for dementia. I'll talk about the third one and more. Oral diseases and inflammatory burden in Alzheimer's disease, periodontal inflammation and mild cognitive impairment, periodontal disease and the bacteria with relation to pathogenesis of Alzheimer's disease, oral frailty and neurodegeneration in Alzheimer's disease. And this one's interesting. Can oral health and oral-derived biospecimens predict progression of dementia? Now, we heard people talking about getting blood, getting cerebrospinal fluid. Wouldn't it be much easier just to spit in a tube or just have a little plaque scraped off your teeth? That'd be good. The effect of periodontal disease on dementia and cognitive impairment, relationship between oral bacteria and Alzheimer's disease. So I want to go a little more in depth on two of them, because this one is one of my favorite studies now. It's switched from bacteria and carotid arteries to this. But chronic oral application of a periodontal pathogen results in brain inflammation, neurodegeneration, and amyloid beta production in wild-type mice. Now, we heard about amyloid, but what they did in this study is they took a periodontal-causing bacteria called Porphyromonas gingivalis, and they gave it to mice orally to give them periodontal disease. And the fascinating thing is when they looked in the brains of these mice, they found this bacteria in the brains. And even more interesting is that they found the changes that we see in human brains on autopsy of people with Alzheimer's disease. They saw these same changes in the brains of these mice that they gave this oral bacteria to. And so all the studies that I have mentioned have sort of been an association. We can't prove anything. And what's really interesting here is this study actually suggests that there may be a causative relationship between periodontal disease and Alzheimer's disease. And so what they did here is they looked at a bunch of things and they said, well, chronic periodontitis increases the risk of getting Alzheimer's disease, and that's brought out in a bunch of studies. And then they mentioned this mouse model, and they say, well, oral infections with this bacteria, Porphyromonas gingivalis, has shown that the brains of these mice develop the neurofibrillary tangles and the amyloid plaques that we see in humans upon autopsy. We also know that this bacteria is in the brain, and the bacteria can cause inflammation in the brain, and that can affect memory. And the conclusion, if you all need one more reason to brush and floss every day, is maintaining a healthy mouth and managing gum disease with good oral hygiene and routine dental care throughout life is likely to reduce the unnecessary burden of Alzheimer's disease in some individuals. Now, granted, this is not the only cause that people get Alzheimer's disease, but boy, if you could knock down one of them, isn't that good? So to summarize all the studies that were in there, chronic periodontal disease increases the risk of getting Alzheimer's disease. Oral infections with Porphyromonas gingivalis in mice show changes that we see in the brains of humans with Alzheimer's disease. We've seen this bacteria also in humans in autopsy samples too, so it's not just in the mice. So we're finding this, and this is oral bacteria in the brains. And oral bacteria can cause inflammation, which can affect memory. This is interesting too, which is sort of what the conclusion of the other study was, is that the pathologic condition of Alzheimer's disease, by doing good oral hygiene, we may be able to regulate that and decrease some of the risk with that. There's also a strong link between oral health, how well you function, chewing ability, and deterioration of cognitive health during aging. Other studies too have shown that there's a relationship between tooth loss and cognitive impairment and dementia. And what they find is people with less teeth or less chewing ability are increased risk for getting dementia later in life. So keep your teeth. On an aside, though, what was interesting too is that if you're missing teeth and you replace them, it decreases your chances. So which is good to know, because it's not, we can replace teeth a lot of different ways now. So controlling oral bacteria and improving chewing may decrease dementia. And then going back to, so I mentioned before about wouldn't it be easy to spit in a tube? Well, this study actually suggested that experimental clinical studies suggest a link between oral health and the development of Alzheimer's disease, suggesting that oral cavity could be a source for important biomarkers, and we've heard a lot about biomarkers today, as well as a potential modifiable target for Alzheimer's disease prevention, which is what I mentioned before, by brushing and flossing. And that leads me to, I know a lot of people here are interested in research, and we actually have a study that we're getting going now where we're going to look at the integration of, the association of oral microbiome and Alzheimer's disease biomarkers. And this is a study that I would encourage everybody to participate in. Those of you who are donating cerebrospinal fluid, I can tell you that we have way less demands on you for this study. So this is the information. If you have any questions, you can contact Dr. Yang, is the principal investigator. I'm also a co-investigator, so keep that in mind. Oral health and dementia, it's bidirectional. So I've been talking a lot about the relationship between oral disease and dementia. Well, dementia, Alzheimer's disease, also is going to impact oral health. And what happens is, at some point, you may forget to brush your teeth. Okay, if you're living with somebody, they could just remind you, brush your teeth every day. But as the disease progresses, you are going to forget how to brush your teeth. And that's when it's really important for somebody to step up and actually take over your oral hygiene. One of the toughest things that I see as a dentist is having somebody come in who obviously cared about their teeth because they had all these crowns, bridges, beautiful dental work, and now because they were no longer able to take care of their teeth, it's all falling apart. And that's, a lot of times I hope they don't really realize what's going on because they would be really upset about it. Dementia also going to impact oral care because, okay, you forget to brush your teeth, but so the hygiene is going to go. But there's also, if somebody else is doing it, that doesn't mean it's easy also because there's care-resistive behavior. They may not want somebody brushing their teeth, so they're going to fight you on it. Finding a provider that's willing to provide dental care for people with late-stage dementia is not an easy thing to do. Transportation issues, financial issues, adds up to accessing care is often difficult for people with dementia. So you can't give a dental talk without talking about prevention, and it's the same for everybody. Brush your teeth twice a day, floss your teeth or clean between them at least once a day. If you have dentures, take them out at night, let them soak. Another point about dentures is that they're not forever, right? The mouth is always changing. Dentures is plastic. It stays the same. So periodically, you may need to have them adjusted, relined, even remade. Watch your sugar intake and routine dental care. All right, that's for everybody. How about for people with dementia? It gets a little more complicated. One thing that I always like to point out is that try oral hygiene, try brushing every single day. And I don't ask people, caregivers, to floss because that's just way above and beyond. And there are some that do it. They're religious about oral hygiene and they get in there and they floss. But at least, get in there and brush. And again, try every day. Every day is a new day. If you're resistant today, if you're getting a hard time, maybe tomorrow, maybe a different time of day. Yeah, ideally we'd like to do it after breakfast and before bed. But if you can get it in once a day, you're going to disrupt the plaque, and that's going to be really good. If people can do their own mouth care, just remind them and let them do it. And fluoride. I can't stress fluoride enough. Fluoride is the #1 best thing we have to prevent cavities. And it's not just for kids. And I write a lot of prescriptions for toothpaste with a much higher concentration of fluoride because we know that this works. As far as doing it, it's really difficult to brush somebody else's teeth. Make sure you have everything you need in front of you. And these are general. This isn't specific. Sometimes it works better. But as a general rule, we like to stand in front of people with dementia. Just because they see you, you're not startling them so they don't become agitated. Talk through the procedure. If things get rough, you can actually start to sing. I used to do that with difficult patients. It's a distraction, and enough times you can get in there and do it. Don't force the mouth open, and use a toothbrush. Everybody thinks those little sponges on a stick are the answer to oral hygiene. because, when I use a toothbrush, the gums bleed, and if I use this toothette, they don't bleed. They don't bleed because it's not doing anything, okay? It doesn't remove the plaque. There's a lot of studies that have shown it. And if the gums are bleeding, it means that there's inflammation or worse, and it means you need to keep brushing so you can get rid of that. And what I like to say just in general, too, is that stay calm, things take time, invest time for better dividends. Oh, and I also get this question a lot. I try and brush Mom's teeth and she just chews on the toothbrush. That's good. Well, the bad side is you got to replace your toothbrush a lot. But when you chew on the toothbrush, you're forcing the bristles in between the teeth, you're disrupting the plaque, so there is a benefit. Other things to be concerned about, dry mouth is the biggest problem, or one of the biggest problems that I see in older adults. I will tell you that it could be devastating to the teeth. Most of the time, it's a medication side effect, just because there are over 750 medications that cause dry mouth. You got to watch what you do for it. Water is going to be the best. You got to watch the sugar intake. Don't start sucking on hard candies, cough drops. There's a bunch of products that are for dry mouth specifically. And again, just watch that sugar intake, and you don't want it sitting on teeth. Other things to be concerned about, just as a general rule, sores that don't heal, swellings, red areas, white areas, changes in sensation, dark spots on teeth, teeth becoming loose. Those should all alert you, hey, somebody should probably check this out. Leave you with just a little tooth trivia. The mouth is part of the body. So if you don't remember anything I told you today, just remember that. Everything else follows. You do not lose teeth because you get older. Your gums don't recede because you get older. These are not normal changes with aging. Teeth do darken with age, and that's why a lot of people want to bleach their teeth when they get older. Teeth also do become less sensitive. The nerve in the tooth shrinks, and one positive thing is if you need a filling later on in life, you might not even need to get numb for it because the tooth has no feeling. So there's a good positive. People without teeth do need oral examinations, and fluoride, as I mentioned before, is not just for kids. So remember, the mouth is part of the body, so disease in the mouth may influence disease in other parts of the body and impact the general health and overall well-being of an individual. And preventing dental disease can help maintain general health and positively impact quality of life. A healthy smile is ageless. And I'll leave you with this because this is one of my favorite sayings now, is we don't stop playing because we grow old. We grow old because we stop playing. So I encourage everybody to keep playing. Thank you.
We have some questions and answers. I've given Dr. Graff-Radford his, and Dr. Hendler, we've got yours coming. So we're going to pass the mic, and we're waiting. There we go.
Mike's for everybody.
One more cheer.
The question was, can a person determine brain disorder from a 15-minute MoCA? That's the Montreal Cognitive Test. And the answer is no. It could be part of the evaluation, but you need the whole story. I find, anyhow, that the MoCA for underserved folks is not a really good test. We find that the numbers are distorted. So, but that alone, even if it was another short test, I don't think it tells the whole story.
Oh, okay, we're gonna rotate around. Okay, so my question is, what is an alternative to trazodone? So for those of you who don't know, trazodone is a common prescribed sleep medication. It's not a benzodiazepine. It's actually an antidepressant prescribed at lower doses. So the answer is, what is the first-line treatment for insomnia? The answer is cognitive behavioral therapy for insomnia. So it's actually not a medication. Now, if you followed all of Dr. Johnson's recommendations, and those don't work, that's called sleep hygiene. What are the next steps? Number one, you can actually just go purchase a CBTI, that's what we call it, workbook, actually from the bookstore for about $10. But the other second thing is the snoring imitation that Dr. Johnson did so faithfully is actually really worth remembering because a lot of people need to get a sleep study. Sleep apnea, age is just a risk factor for sleep apnea, and often I find it gets back to the same theory, that people are using psychotropics to cover up an underlying medical disorder, whether it's REM sleep behavior disorder, sleep apnea, restless leg syndrome. So the answer isn't trazodone. The answer is CBTI and get a medical workup if you haven't gotten one.
Oh, we got it. Well, this first one says, how important is gut health in relation to overall brain health? And I'll be honest with you, I'm not positive because I haven't researched it. I know they're looking at just gut health in general and the gut microbiome. I can get back to you on that after we do more research. I think there's some connection, but I'm not aware of, and I know I was talking to Dr. Law earlier today, and they have a bunch of data, but I don't think anything came out really strong about that yet.
Are there strategies therapeutic for regenerating brain cells? And it always was thought that you couldn't get regeneration of the brain in humans. But I think there's now very clear evidence in animal models, certainly, and probably some in humans, that you can regenerate some of the hippocampus. Certainly exercise increases the volume of the hippocampus, whether it's regenerating new cells or making the hippocampi bigger for other reasons, or treating sleep apnea, increasing the hippocampal volume, or learning to become a taxi driver in England and having to learn all the streets. That was before Uber. Their hippocampi actually increased on MRI. So cognitive training. So there are some evidence that certain parts of the brain can have some regeneration.
All right, great. So I'm going to actually combine two questions in one. So essentially, what is the relationship between various psychiatric diagnoses, including trauma, such as PTSD, ADHD, and dementia? Okay. So let's go over what we do and don't know. So in brief, there was very strong data showing a relationship between depressive symptoms and dementia. It's a dose sort of response relationship. The more depressive symptoms they have, the higher the risk that someone has of developing dementia. Anxiety is a little less clear in terms of a risk factor, but there is some evidence for that. So trauma-related disorders, that's mostly been studied in the military. We're still beginning to understand the importance of civilian trauma. The strongest evidence showing that PTSD increases the risk of dementia by about 1.5 was actually a large database study done of the veterans showing a relationship between PTSD and dementia. By the way, PTSD is actually separate from anxiety. I know a lot of people clump those together, but actually the fMRI data suggests those are different. We think it affects the cortisol levels and actually causes damage to the hippocampi. Finally, learning disorders, which includes ADHD. So there's still a lot of actually better understanding of adult symptoms of ADHD, but one of the reasons that the MOCA is often invalid in various diverse communities, that there's often undiagnosed learning developmental disorders, and that's why getting a really good history is so important. And so more to come on that. That's a huge area of study. Suggestive, but we need to study more.
I just want to chime in too, going back to the gut microbiome. If anybody else has anything they want to add about that, I'm free to pass that off. The next question, CPAP usage seems to cause dry mouth. What do you do? Yes, it does. And it's supposed to be humidified air, right? There's supposed to be a way to do that, and people still complain about it. Suggestion, just general for dry mouth, is sometimes if you just put a humidifier in the bedroom while you're sleeping, just to really bump up the humidity in the air. And I will tell you, keep it next to your side of the bed. Don't put it on the other side of the room. The other thing is that there are now, well, there have been oral appliances for sleep apnea. And you may want to, there are dental sleep medicine specialists that make these oral appliances and some prosthodontists, and you may want to consider that because that's just going to go in your mouth. You're not going to have air blowing up your nose all night, and that so you can sleep with your mouth closed, and that in combination with a humidifier may solve the problem.
Does research or take into account consideration whether a person is an auditory or visual learner, or the most receptive attributes? I'm thinking of the neurologist who asked my mom to remember and repeat 3 words and draw an analog clock. So we actually, when we evaluate patients with cognitive difficulty, we look at multiple domains. For example, we look at memory, we look at attention, we looked at visuospatial, we look at language, we look at executive decision-making as part of the cognitive test. So a psychometric battery would cover all of those things. These bedside tests that were given to this patient's mom has a little bit of both of them, but it does take into account all the various strengths and weaknesses, and the pattern is actually very, very helpful. In fact, one thing I would leave with you is that you should look at the strengths of the patient, not just the weaknesses. So in Alzheimer's disease, for example, you usually have people able to walk around, they can see, they can hear, they can taste, their primary senses are intact. They have very good social graces. They communicate, but if you at a cocktail party, you wouldn't know there's a problem. But if you ask them specifically what's the date today, no idea. What did you have? What did you do yesterday? No idea. That's the short-term memory. So we look at what's preserved, because the anatomy of Alzheimer's disease isn't everywhere. The motor areas and primary sensory areas are often well preserved. The basal ganglia, the cerebellum, are not affected. So it's actually very important to look at the preservations.
One more. Okay. Yeah, okay, I was asked. So another question I got is, what is any side effect of a drug known as gabapentin? So without going into too much detail for those of you who are not familiar, so gabapentin is essentially a medication that's often given for neuropathic pain. It is also given for headaches, and actually it's a seizure medication. So all drugs do have side effects. One common side effect we do see from gabapentin, which is commonly prescribed for pain, is some people do experience, cognitive sort of effects. They're just not as clear-minded. But I think I want to take a step back because people get very tied down with like a particular drug. This is where a geriatrician can be very helpful. It's important to take a look at that drug in the context of all the medications they're taking in polypharmacy. So usually when I see gabapentin, I see it with a lot of other meds because they're prescribing it to try to treat pain. And one really important thing is to take a step back and say, is this the most effective treatment for pain? Have we tried other non-pharmacologic practices such as cognitive behavioral therapy for pain? There's TENS, there's other things. So rather than getting too sort of tied down with the medication, I take a look at the symptoms they're trying to treat and trying to say, is that the most effective approach? Is having 3 pain meds the appropriate approach?
So this question, what is the dental industry doing to prevent life-threatening infections that occur from routine dental procedures? First thing I guess I would like to say is that I think that's really, really rare to have life-threatening infections. Infections are possible. It's the human body. People react differently to things. But the dental industry, it basically comes down to, I think, training the dentist. So we do procedures, and sometimes people get infections post-procedure, and it's understanding, what the risk. Certain procedures have more risk than others as far as infection, and maybe antibiotics are indicated in those situations. And being in touch with the patient, and also, if the patient does experience symptoms, to get to contact the dentist or go to an emergency room if it's life-threatening to deal with it. So I think that's sort of, just being aware and being able to react and to treat medical emergencies that occur in the office, and we're trained to do that.
Does you have any more?
I'm gonna summarize one last question, because this is the big one we really get about THC and marijuana. Okay, so all right, so let me just kind of sort of break this down a little bit. So thinking just about symptoms, there is actually an interesting clinical trial looking at agitation and the use of THC to help with that symptomatically. I think one thing I just want to emphasize is getting sort of over the counter or from sort of, I guess, not regulated sources. One doesn't actually know what they're getting with the marijuana, so it gets a little tricky there in terms of treating mental health risk factors. And once again, I do actually encourage non-drugs such as psychotherapies and other approaches like music, aromatherapy to address mental health conditions. The cognitive effects, again, are less clear, but if we think about the cardiovascular relationship, some evidence of marijuana affecting the heart adversely. So if we think about that, there could be concern. And then finally, I think somebody asked about vaping in younger populations. So vaping is kind of tricky, but one thing I did want to point out is what makes vaping very interesting, I know it's actually from my ICU friends, is that it actually dissolves something we call surfactant, because it's oil-based. And believe it or not, your lungs actually have these alveoli at the bottom, so it's kind of like these sort of elastic things that allow you to breathe. And there's actually sort of an oily substance called surfactant that allows it not to stick with each other. But vaping can actually destroy that. So probably a conversation for another day, but understanding the relationship between lung disease and Alzheimer's is a huge one. And if we begin to think about the importance of good respiration, O2, aerobic exercise, right? That's why we saw those hippocampal growth effects. Probably don't want to do anything to destroy your lungs, including vaping. So I would say no to that. You didn't put it on your list of things not to do, but we should probably just add it for those younger folks. Okay.
Thank you very much to our very distinguished panel. You can do better.